Welcome back to A Time for Change. The ongoing coronavirus pandemic has disproportionately impacted minorities and vulnerable populations. And amid mounting staffing shortages for many health professional roles, one new statistic stands out. The number of Black medical student enrollment seems to be on the rise, up 21% in the past year, according to a recent NPR report. Here to discuss that and more is Michellene Davis, CEO of National Medical Fellowships and a former hospital executive. Michellene, thanks so much for joining us today.
Thank you so much for having us.
So I want to get your take on this. Black enrollment up, that seems to be tied to the pandemic, is it not?
I believe that it is in fact tied to the pandemic, but also the sense and sensitivity around the level of awareness of the impact and effect of that pandemic in communities that have been made vulnerable as a result of historical disenfranchisement and underinvestment. We literally are seeing the fact that for those of us in health equity who have been talking about how structural and systemic racism and inequity has really created vulnerable communities across this country, that now that others have seen it as well. And so I firmly feel that the students who have applied in these increasing numbers, which is a fantastic thing, not just for us, but for everyone, that truly it is as a result of seeing the impact of something like this virus literally hitting communities of concern, featuring individuals that they love and know, and understanding that they have an opportunity to do something about it.
And Michellene, I'd love for you to really illustrate what that inequity looks like. How equal is the care that people are getting these days? Can someone like me walk into the emergency room and know that I'm getting the same treatment as, let's say, a white man or an Asian woman?
Well, my friend, the issue there is that what statistics tell us is that there's a high probability, a high likelihood that, in fact, you would not be receiving the same level of care. And that is despite your level of income. That is despite your coverage, your healthcare coverage, whether or not you are a government subsidized payer or whether or not you are a private payer. That is despite your educational attainment and socioeconomic status, right? So what we know is the fact that we really need to strive for a more equitable future where everyone really has an opportunity to the same level of high quality, high culturally competent care. And that is not something that right now we can guarantee that you are actually receiving. And that is not just me that is saying that. Undoubtedly, study after study has evidenced the fact that implicit bias and outright structural and systemic racism has so perpetually influenced the American healthcare system that what we see now is not just the fact that there are certain health outcomes that are bettering, but that literally, as the general population's health outcomes are better, that for BIPOC, that is Black, Indigenous, persons of color, their healthcare outcomes are actually worsening. And so as a result of that, what we are seeing is the widening of the health disparity gap across the country. And this is in many different areas, unfortunately. Lots of folks and lots of talk have recently been really focused on maternal mortality. And the fact that a Black woman with an advanced degree has the same or worse outcome of mortality than a high school dropout who is white is something that is significantly concerning. But when you take a look at the fact that in certain pockets of this country, like New York, for example, a Black woman is 12 times more likely than her white counterpart to literally pass away after the process of actually bearing a child. There needs to be some time for someone to say that is enough. And one of the things that I like to say at National Medical Fellowships is the fact that we are done dying. And so what I believe that we are seeing right now is that students have said, not only are we done dying, but we are also at a point where we realize that we are an aspect of the answer. We are the actual solution for our own communities. And so as a result of that, we literally are seeing the fact that the same students who over the past summer have taken to the street in order to march after the horrendous and unjust murder of George Floyd have now marched into medical school admissions offices and will be marching into medical school.
Michellene, I want to talk about all of this because we know, you and I have talked over the years about population health, which became social determinants of health, which now became health equity. We've seen that metamorphosis of the idea of exactly all of this, and it seems like we somehow end up having the same conversation. So looking at all the data that we have now, looking at the movement and the focus on health equity right now, where's the solution in all this? Does it come largely from a shift in the population of caregivers? Does it come from maybe just more data in the hands of everyday individuals? How do we move forward from just having this conversation over and over again?
Thank you, Anjalee. I actually think that indeed it's a multifaceted approach, but it is an approach which incredibly depends upon the diversification of the healthcare workforce. And when I say that, please know that I am indeed focused on the physician, but not just the physician. What we have seen is the fact that across the country, state legislation has increased the access and authority for individuals like advanced practice nurses and physician's assistants. So we need to make certain that indeed all of these areas are areas where individuals from the communities of individuals that they are serving, right, that they are present in those spaces. But we also need to make certain that we are holding individuals and institutions accountable. I mentioned earlier cultural competency. Well, that means that you have to face your implicit bias not once a year in some diversity and inclusion training. That means on a daily basis, you as a healthcare practitioner must challenge yourself, understanding all full well, not just the fact that here we have this data and these outputs today, but that historically, healthcare has literally been built on the backs of impoverished and oppressed individuals, right? So if we take a look at just the science of obstetrics and gynecology alone, what we know is that Dr. Marion J. Sims literally built it on the literal backs of African Americans who were enslaved, women who were operated on without anesthesia, right? So we know that this has happened, and yet healthcare institutions at times like to move forward without actually looking back and understanding that there must be something that occurs that evidences that, yes, this happened, we acknowledge it, we recognize it, we wish to correct it. And so as a result of that, we're going to make certain that our own systems and practices and processes and procedures, that who we hire and how we hire, who we recruit, how we retain and matriculate is reflective of our contribution to systemic racism, right? So to that point, you ask about the data. Is it important to get data into everyone's hands? Well, I think this. Not only is it important for just those of us who are devoted to health equity to be well educated about this and to understand it, and not only is it important for the healthcare provider, but it's also important for the everyday patient. Individuals understand, and over 48% of African Americans have indicated that they have experienced a negative experience in a healthcare setting within the last year. So what we know is the fact that if they are also given the data and provided with an opportunity to truly be empowered to advance this for themselves, and if they are doing so within a system that acknowledges what their historical contribution has been to the disenfranchisement, marginalization, and poor healthcare outcomes for certain populations, then we may actually stand a chance. But there is no way through this problem, over it, around it, or under it, that does not center a focus on the need, the evidence of the impactful need, an immediate need to ensure that we are achieving higher levels of diversity in the healthcare workspace, especially in clinical spaces. And Anjalee, I'll tell you this, I did not leave high academic medical center system in order to come to NMF just to ensure the pipeline of BIPOC students interested in medicine. I came here to ensure the pipeline of BIPOC physician leaders. We need to make certain that these individuals are poised and given the opportunity to lead the systems and structures that we have already known for years that they need to change, right? And so we need to make certain that they're having access to the opportunities that prepare them, equip them, not just recruit them, but then create environments in which they can thrive, not just survive, in order to ensure that they're matriculating to leadership positions. And that, my friend, may finally get us over the trenches and actually to the land of health equity.
Something that we know we've seen across industries as well. Unfortunately, we have to leave it there. But Michellene Davis, CEO of National Medical Fellowships, thank you again for joining us today.
Thank you for having us.